How was it?
As always, not terrible, but not good.
All right, cool. So I mean, I looked over the scores. I don't see the individual scores, but I see like people's averages from the last couple of weeks. You guys are doing pretty well. Like this is residents and fellows included. We're averaging about like 50 to 60% on these quizzes. Not too bad, which I think is pretty good. Um, I'm sure. So, all right, cool. Let's get started. So, um, first question, this one kind of asked about, right, like the patient that uh, really got diagnosed with C. diff after a prolonged ICU course with multiple courses of antibiotics. They got oral vancomycin. It was presumed that they have a ventilator-associated pneumonia. However, all the cultures were negative. They improved after 5 days of therapy. And therefore, what really should happen is that the IV dose and then IV vancomycin should be discontinued. And so when you look at, like really the treatment for CDI, we go by like, IDSA guidelines, or you can look at like the other one is the Society of Healthcare for Epidemiology of America. And so really when you're classifying CDI, which is, C. diff infection, you're looking at whether it's severe or non-severe. And severe usually warrants an ICU admission, maybe not so much anymore, but really because, their white count's insanely high, their creatinine's high, they're old. These are just like risk factors. But the thing that gets concerning is that they're having 10 bowel movements a day or an elevated lactate level, usually because they're hypoperfusing, and then they start to develop signs of clinical instability. Non-severe disease really is just the opposite, right? It doesn't meet this criteria of the laboratory things that we went over, or like the clinical symptoms that we went over. And then for that really severe and non-severe, you're going to treat with um, oral vancomycin 125 4 times daily for 10 days for an initial episode. And then you can also throw in fidaxomicin 200 milligrams twice daily. It can be an alternative, or you can use it for recurrent or refractory disease. But for critically ill patients, a lot of these patients won't be able to tolerate oral therapy. So then you can consider IV flagyl, and that's going to be 500 Q8, orally or IV along with that vancomycin therapy. Now, the things that get concerning and that you want to assess every patient for is like extreme abdominal distension. When you start to develop less diarrhea, because then at that point you're concerned about toxic megacolon, and really due to the amount of inflammation that's happening in the colon, your definitive treatment for that is really a colectomy. We all like make kind of fun of it, but really cool stool transplantation, which is like you endoscopically give stool from a donor. You do it for like refractory or recurrent disease if you're trying to avoid surgery, or for those who aren't good surgical candidates. And then regardless of what therapy you choose from this table, have to remember that it all starts with removing the antibiotics that caused it in the first place. And so there are cases where like concomitant antibiotics have to be administered. And for those cases, really try and attempt to narrow down your antibiotics or shorten therapy, because in those that you continue their antibiotics where you decide it's absolutely necessary, the treatment success of treating CDI is much lower, and then the relapse rates are much higher. Cool. So this next question, woman had a syncopal episode, found to have a large PE, undergoes CPR because she has a PA arrest, she gets ROSC. What's really your next best step? And so very important with these questions, always look at what the question is asking. What's the next best step, right? So once you've been able to define what's, your diagnosis of PE, you keep it very simple. Is it, because your treatment's really based on your severity, right? Is it massive, submassive? And really, I think that submassive definition is starting to go away, or unmassive. And really, the way I think about it, are they the stable patient or the unstable patient? Because if they're the massive patient, meaning, the highest risk of death from a clot, I'm thinking hemodynamic instability, like sustained hemodynamic instability that's attributed to the clot itself. Maybe they're requiring pressors, whatever, right? You do your ultrasound, you see that right ventricular dysfunction, you see that right ventricular failure, all because of the massiveness of the clot or the clot burden. These are the patients who are at high risk of arrest, and I'm not wasting any time. I want to do thrombolytics. And so, yeah, you have your contraindications, right? Like the major ones that we talk about, intracranial neoplasms, recent intracranial or spinal surgery, hemorrhagic strokes, active bleeding, recent non-hemorrhagic strokes. And even these, I want to make it very clear, these are relative contraindications, because we've had patients who had the brain bleed, like they're here for a subarachnoid hemorrhage, and you keep them off DVT prophylaxis because you're concerned about the bleed. And then within 24 hours, while watching them in the ICU, they develop a concerning blood clot. What do? We give TPA, regardless of the bleed. Why? Because there have been studies done in which this exact scenario happened. These patients survived because the clot is going to kill them regardless, and then you can manage the brain symptoms later. Now, yes, fine. There are indications where patients may not be a candidate, and you're at a center where without delay, you can do alternative interventions, such as, a catheter-directed thrombolectomy or even clot extraction. You guys have seen some cool cases of that. So, time is obviously of the essence. Delaying thrombolysis to insert a central line, which is one of the other choices, is not ideal. And you can actually increase the risk of bleeding once the alteplase is given. So if you think you need a central line, put it in before you give the alteplase if you have that time. So what I'll usually do is I'll do it femorally for the intensivists on the call. So if you guys have already given the thrombolytics and then you decide to put it in the line after, it's not a contraindication. You can actually do it. Things that you can do to mitigate life-threatening bleeding, such as profound hematomas and things like that, is obviously with ultrasound. Make sure you never back wall. You go only with one stick. So if you're going to go in, make sure the cleanest stick that you can, so you minimize any trauma. It's like you want to go in with. Have you guys seen those videos of those dentists that are injecting a needle into a balloon without puncturing it? Yeah. This is exactly what you're trying to do. You want to minimize any bleeding, and it all relies on the perfect stick. I can't do it. So
I had the pleasure of doing one of those cardiac arrest patient. I had to do both a central line and an A line after they'd just given TPA in the ED. That was fun.
Yeah, and I mean, so you probably, the good thing is with ultrasound, right? You make sure we shouldn't be backwalling anyways, because we're not doing them blind. But you just go in with the cleanest stick, one straight shot, and then it's clean, and then you shouldn't really have any issues. Cool. So the question about VA ECMO, right? So that's going to provide both respiratory and cardiac support. And this patient, yes, they have respiratory and cardiac failure due to a large PE, but the patient is already stable, and the amount of time it's going to take to get this patient on cannulation is pretty ridiculous. So to think about transferring to another facility for catheter-directed thrombolysis, embolectomies, VA ECMO, it doesn't really make sense, right? And then when we actually talk about catheter-directed embolectomy, no evidence that it actually improves mortality. It does improve symptoms. When you talk about these patients down the line, when you follow up with them 30 to 90 days outside the office. But it can be something you consider if thrombolysis is contraindicated. Other things that, just kind of caveats, how much do you give if you think okay, maybe there's that relative contraindication, maybe they have that brain bleed, do a half dose. And if it doesn't improve, then do the next half dose. There is some evidence of clinical experience of using inhaled nitric oxide for these cases as a temporary maneuver. And then, obviously support that work of reading, try avoid intubating these patients, because what's going to happen, you have a clot that's causing RV strain, and then you just dramatically throw on all this positive pressure. What's going to happen? It's just that little extra push that you needed to give them to throw them into arrest for that right heart to fail. Oops. All right, so this next question, kind of bread and butter, both internal medicine and critical care. So you have that patient that had that inferior wall STEMI, they got a cath, they got 100% occlusion of the right RCA, or the right circumflex, drug-eluting stent placed. Now, 2 days after, they're monitored in the ICU, they get short of breath, they decompensate, you intubate them, they're on pressors, those are your EKGs. The important thing is that it's unchanged from before. And then you see the chest x-ray, right? And then you do your TTE, which confirms your diagnosis. So you know that, okay, the question is asking for a diagnosis. It's a three-part question, right? What's a complication that can happen after MI? What is a complication that I can pick up on ultrasound, which is going to be most all of them? And then what's the treatment that I need to do that can help support that complication, right? And so the answer here is that you need to put them on a, it's the correct answer is putting on a balloon pump. And the reason is, so when you talk about what the problem is here, your potential options of what could have gotten wrong is that you could have had a papillary muscle rupture. You could have had a ventroseptal defect. You could have had a pseudoaneurysm. You could have a free wall rupture, right? And so when you have a papillary muscle rupture, which fits the time course about 2 to 7 days after, it's the big one in the setting of where that vessel is, which is the RCA inferiorly. You're concerned about a acute papillary muscle rupture causing severe acute MR. because the RCA can occlude around, go backwards, and then supply that back wall of that vessel, right? Because this is why we do TEs, right? In order to look at the TE, we have to go all the way back into the esophagus because that's the closest site, and then the RCA goes around backwards. So right in the front, left on the side and the back, your left atrium is supplied by the RCA. So the reason why would you do a balloon pump? And so when you talk about the balloon pump, what are you trying to do, right? The idea is that like this person, right? So how does a balloon pump work? For those of you guys that don't know, is that in diastole, you are inflating the balloon. And by inflating the balloon, this is a balloon that sits in the aorta, in diastole, when you inflate the balloon, you will create a back wall pressure that will send more blood flow into the heart. Therefore, more blood flow going into the coronaries, supplying those areas of those blood vessels. And then you dramatically flatten the balloon doing systole. The moment you do that, you supposedly decrease the work. Yeah, you do reduce the afterload during systole. Because not only are you taking away the afterload, you've had this pressure gradient from a balloon, then you have it collapse really quickly, takes away that pressure gradient, dramatically decreasing the afterload during systole. So it times up with the heart rhythm, and then inflates during diastole and deflates during systole. So the way you would see this, for those of you guys taking your echo boards, or even just for ultrasound, you would look for a really severe MR jet. When you're doing like left-sided, you can do it on a Plax view, an apical 4 view. So like this patient underwent a right-sided cath. The pulmonary capillary wedge pressure was around 34. And if you remember what like the V wave was, then it decreased to 22 after the intra-aortic balloon pump placement, which supports decreased afterload, improved diastolic filling. Now these days, these complications are infrequent, but still associated with high mortality rates. And so if you see this, requires urgent surgery, but usually also requires temporizing measures, usually with mechanical circulatory support. And then so once again, like 2 to 5 days after an inferior or lateral wall MI, and then your goal is to reduce the LV afterload, therefore like preferentially directing blood flow across that aortic valve. Meds that you can use, nitroglycerin, nicardipine, and then, the 2020 AHA guidelines still recommend using a balloon pump to kind of like that reduce that LV afterload, augment that cardiac output through this like balloon pump counterpulsation. So VV ECMO is not going to provide circulatory support because it's only going to address hypoxia, right? Veno-venous ECMO. Now, why would you not do VA ECMO in this patient? Why would that be difficult to use for this patient? So with how an ECMO cannula works, right, is that you have a drainage cannula and a return cannula. And so that return cannula is going to provide, usually go into like a femoral artery. And that's going to increase your afterload against already a weak heart, right? So VA ECMO without something like a balloon pump or an Impella is not going to be effective. Mitral valve transcatheter edge stretch repair, which was like one of the answers. So you're basically like repairing to clip the anterior and posterior leaflets. You can consider that in patients with chronic primary MR with severe symptoms, who have a high surgical risk, and in chronic secondary like functional MR, but not something acute like this. And then the reason you're obviously not going to do PCI is you're not concerned about an acute occlusion because the EKG is really unchanged from before. Any questions about that one? Cool. So this next one, like this one, you can really just look at that. And I generally like to look at the question and the answer choices first before reading these long question banks. Because even this one, you can really just look at the question and the answer choices, and it's saying like, which of the following is true about placing an endotracheal tube, right? And most of this will apply to any patient. Maybe with that first answer choice, I'm going to go back and see like maybe are they hypotensive or not. But even then, that's not going to change my answer. And so the correct answer here is that using video laryngoscopy is going to increase your first pass success, but does not decrease the incidence of severe complications compared with direct laryngoscopy. Keeping in mind that the answer is a bit different now with the new device trial that came out earlier this year. We do see decreased risk of complications, just nothing significant. So, this patient had hypoxic respiratory failure from pneumonia, possibly an aspiration, possibly an empyema. You intubate them, and you need to intubate them because to support their work of breathing. So, two biggest complications that we are all very used to after intubating is hypotension and hypoxia, right? And so, the idea is that the shorter time from induction to successful intubation, decreases the chance of basically complications from intubating. And then using video laryngoscopy improves the chance of first-pass success rate, time to intubation, therefore decreasing the chance of that hypotension and hypoxia. And really, it's because you're able to get a better view of the glottis. That's why we call it like video epiglotoscopy instead of really video laryngoscopy, because that's what we're really trying to do. In previous trials, it didn't show that, it translated to like fewer complications, specifically hypoxia, hypotension, vasopressors, cardiac arrest. Regarding the etomidate versus ketamine thing, so the thing that we get concerned about etomidate is that even like a single small dose of etomidate that you could use for RSI can inhibit the production of cortisol in the adrenal gland for like up to 24 to 48 hours. So you get concerned about like massive AI, and then they go into like refractory shock. And then randomized control trials have really demonstrated no benefit of ketamine over etomidate in patients that are critically ill or septic. Apneic oxygen delivery with nasal cannula, like even high flow throughout the process of like intubating them, has not, including like after you give induction meds, hasn't really changed outcomes. In theory, yes, it makes sense, but really trials have failed to show that in critically ill patients, there's no difference in like the lowest oxygen saturation that you get or in incidence of severe hypoxemia. And part of that makes sense, right? Because you're not addressing the ventilation at that point. Once you give your induction meds, you can't ventilate. And then regarding like the sucks versus rock, I know everyone like hates sucks because sucks. But you really only see like because sucks is a depolarizing agent versus a repolarizing agent, and so really you only see sucks cause hyperkalemia in patients that are prone to develop hyperkalemia, right? So patients that have pre-existing hyperkalemia, renal failure, burns, that covering a significant amount of the body surface area, spinal cord injuries, if they have like chronic limb paralysis because their muscle just sits there, if they've been just sitting in bed for a while, or if they have rhabdo. Otherwise, it's safe to use. So just be cautious of it. I mean, most of us will just go straight to rock because we don't want to go through that checklist of things and accidentally make a mistake because it can be deadly. This next question, a little more advanced ECMO question. So, patient is in refractory hypoxic respiratory failure, ARDS, they're on VV ECMO, they have a cannula in the IJ and the FEM. So the drainage cannula in the IJ, in the FEM, and then a reinfusion cannula in the IJ. Now they're febrile, they're hypoxemic. To support them to address this hypoxia, you increase the pump speed appropriately. But now after like day 5, you develop severe desaturations with your SpO2 going from like 99% to 70%, and your vent settings are unchanged and ECMO settings are unchanged. So what is the next best intervention to kind of address this? So what did you guys kind of like notice that's different, right? Really the parameters that you're looking at. So one, you have to address this, right? A patient who's on ECMO, on VV ECMO, should not desaturate, right? Because you're having a machine oxygenate their lungs for them, right? And so they should not desaturate. So things that you can do to kind of address this is look at, your sweep gas flow, your blood flow rate, and then your so, the way the cannula works is that, so the way the cannula works is that the blue is your drainage and then your red is your return. You'll go from your drainage, you go into your pump, and then it'll go into the oxygenator, and then it'll go back into the body, right? And that's why you get that oxygenated blood. So there's 3 areas where you're going to check oxygen and pressures. And those 3 areas are before the pump, after the pump, and after the oxygenator, right? So when you look at pressures, your pre-pump should generate a negative pressure, right? Because you're pulling blood, so it'd be a negative pressure. Then after the pump, after the oxygenator, it should be a positive pressure, right? And so then you check your pre-oxygenator numbers and you check your post-oxygenator saturations, and it should be obvious that your pre-oxygenator number, the one that you're getting from your drainage cannula, should have a low SpO2, and then the one that's going after the oxygenator should have a high SpO2, right? And should correlate with what you're getting peripherally. So what's happening here is that when you look at the biggest thing that you can see is that your pre-oxygenator versus your post-oxygenator pressures are dramatically different, right? And that's because you're concerned about day 5, and that transmembrane pressure gradient has gone up significantly, right? So right now you can obviously localize an issue going on because you should have a pressure gradient, right? Between your oxygenators, you should have a pressure gradient between your pump. There's an obvious issue going on between your transmembrane pressure gradient. Usually less than 50 is okay for a gradient between your pre and post oxygenator. but this high, there's something going on. There's an issue of the blood getting through. And so what do you think that is? Clotting, yeah, right? So that's exactly it. This is what's happening, right? So the transmembrane pressure gradient is extremely high, and it's usually due to a mechanical obstruction from clot. And that's going to prevent blood flow from going across this membrane lung, which will cause a drop in your post-oxygenated pressures. And sudden membrane lung failure is like a life-threatening event that requires immediate exchange of this membrane lung, because this is the whole reason you have them on VB ECMO, right? And so this thing is like responsible for not just oxygen uptake. Yeah, go ahead. Yeah. Yeah. Nope, you have to exchange it out. It's a foreign device. Foreign devices can, so you've got to take it out. So really, when you think about like, it gets a little complex, but for the fellows, really when you break it down to, because it's responsible, keep it simple, right? Oxygen uptake and carbon dioxide removal. So things that can go wrong with this membrane lung, I would just divide it into like three things: hematologic issues, pressure issues, and gas transfer. So gas exchange, actual pressure issues, and then hematologic issues. When I'm thinking about hematologic issues, I'm thinking about like hemolysis, coagulopathy, right? Once again, foreign device, the blood is just shearing against this, right? And then pressure issues, which will signify that there's clot. You don't just have to visualize clot in the membrane. Sometimes that's just too late. Even a pressure gradient should be a sign that there's something wrong with that membrane lung and you should exchange it. And then finally, like issue of the gas to transfer. And if you're not achieving, your membrane lung is working fine, but you're not getting enough gas transfer, maybe you need to increase the flow, like increase the sweep gas flow, which is going to increase carbon dioxide removal, things like that, right? So initially, that's at the start of the case, they were having hypoxia. So what do? They increase the pump speed. Let's get more blood. No, initially it helps, right? But now it's stopping to work, right? Yeah. And so that picture that you saw, right, that clot and that fibrin throughout the membrane lung is like an impending sign of membrane lung failure, and you just have to exchange it out. And so, other things that you can do is you can check like that post-oxygenated blood gas to calculate oxygen transfer across the membrane lung. And yeah, and how would you do it? One team member like cares for the patient, they optimize them on the vent, you increase the support on the vent, make sure they're stable, while the other person exchanges out the membrane lung and manages the circuit. Other answer choices like, so why is it not recirculation? And the idea of recirculation is like, here's your insertion cannula, here's your drainage cannula. If they're too close to each other, what's going to happen? Yep, it'll just recirculate, right? And so how can you test for that? So if it's just recirculating, what's going to happen on that initial, that pre-pump oxygen, that pre-oxygenator SpO2? It'll be high, right? And so you just get a blood gas through there and it'll be high. It'll be similar to what you're getting after your oxygenator, which shouldn't be the case, right? And in that case, to address that, you can just separate the two. Or you can decrease the speed, because if you decrease the speed, it'll allow it to separate, yeah.
So you mentioned that, because for some of us have not seen how long these catheters are, how long are they, like, for that to be a possible issue?
There's a good chance. So the one that you put to the fem is like damn long, right? It's like going in the fem and it's going all the way up here. You see into your IVC somewhere near your SVC.
So I guess it's the same way you get up here.
Yeah, it's huge. Yeah. So a good way to confirm placement is TE. Most of your people that are going to cannulate for VB will do a TE to confirm. Yeah, and it's obviously institution dependent. Now, sometimes like a small drainage cannula can limit ECMO blood flow. So you might have actually put in an additional cannula just to get more venous drainage for like your really severe ARDS patients. Does that kind of all make sense?
Yeah,
All right, cool.
pretty cool though, it's like AA gradient, but you can change the lungs outflow.
Yeah. Wait till you dive into like VA ECMO stuff. That's even cooler.
Yeah.
All right, cool. So this patient, like, I've seen this happen before. It's horrific. So you have a patient that's getting dialysis. They have a dialysis catheter. Now they have a tonic-clonic seizure at home, right? EMS comes in. They see that they get a blood sugar as they should. They see that the patient is hypoglycemic. And what do? They appropriately, to try and give it as quickly as possible, give dextrose through the catheter. What's the problem? what just happened?
You killed the patient.
You came very close to killing the patient, right? So what is sitting in all these temporary dialysis catheters? Heparin, right? That or sodium citrate is because you can't let that, it's a catheter, right? You can't let it clot. So what we always do is we leave a good amount of heparin in there, just enough. Like all these catheters come with how many cc's, because it's just enough to sit at that port so it doesn't enter the body, so that the port doesn't clot. And so what this person did was they opened the cannula, the catheter, they injected the dextrose, and what did they do? They flushed all that heparin into the rest of the body. And that's why you're bleeding. So what do you have to do?
There's nothing for me to reverse. That was a good question.
Yeah. You absolutely, absolutely, absolutely have to be careful about this. So fast forward, right? Like you get all this cool stuff about like, your PTT is elevated, your PT is elevated, your INR is elevated. And so in that scenario, now this is also a second order question, right? If you are able to figure that part out, great. You know the answer is what? Protamine to reverse heparin, right? But what else can you use to figure that out? And the other answer choices will tell you what it is. And it's really going back to like basics. So whether you're a fellow or not, like you guys should have figured this out. And the reason is you look at the coagulation cascade, right? So yeah, right. So I mean, yes, right. So like the problem is like when you think about like DIC, right? Usually you're going to get, low fibrinogen, increased fibrin degradation products. And if you saw that, then you would give your cryo, right? But you don't need to give it. Desmopressin, like a BUN that high, very unlikely to cause platelet dysfunction. And then your vitamin K, that's going to only address stuff like your intrinsic pathway, sorry, your extrinsic pathway. But this thing is affecting both pathways, right? So if something affects the intrinsic pathway, it's going to affect the intrinsic pathway and the common pathway. So if your PTT is high, whatever it is affecting your common pathway and your intrinsic pathway. And if it's something affecting just your PT to be elevated, then it's affecting your common pathway and your extrinsic pathway. This is like the complex way to look at it. This is the easy way to look at it. And if you remember this, you will get all your answers correct. But you just have to remember that caveat that things that will cause your PTT to be elevated will also affect your common pathway. So keep that in mind. That'll help you separate out a lot of these answer choices. The only other thing to be careful of is like your thrombin time, which we don't see that much often, is a measure of how long it takes for a clot to form in plasma when you add excess thrombin. And what does thrombin do? It helps convert fibrinogen to fibrin, right? So you guys see that? And then, yeah. Cool. Yeah, go ahead. Yeah, so your dialysis catheter have large ports, and so it's just sitting there when it's not being used, right? So what they do is in your dialysis ports in those large catheters, it's about 13 to 15 French. It just sits in that chamber, and you just inject just enough cc so that it just sits in that chamber. You inject it, and then you cap it so that it doesn't backfall and it doesn't go into the body. And that's why I always leave my clamps right at the end of the dialysis catheter so that area doesn't clot, because you don't want that blood sitting in there to clot up. But if you're going to use it, like, hey, there's a patient that's like the biggest one, right? Is like the dialysis catheter, because of how large it is a great resuscitation tool, right? Like we talk about these large bore IVs, like what better large bore IV than to have a dialysis catheter in place? So like, oh, I don't have to put a cordis in, I don't have to get like, my two 16 gauges. And then, but you do have to take that heparin out first before you decide to, in massive transfuse this patient with blood. And then along with this blood, you're putting heparin throughout the rest of the body in an already bleeding patient. Have to remember to do that.
I think it's like 10,000, 50,000 units of pepper in there. It's a good amount of pepper.
All right. So which of the following statements regarding physician burnout is correct? Yeah, right. So, ways to kind of tackle this question for those online is that anything that's definitive, that's an absolute, is always going to be wrong, because you can never say anything is absolute. The majority of the time in questions like this, you can just rule out the answer. So, yeah. So really, when you think about like, physician burnout, there's no doubt that burnout is linked to medical errors, right? And if any of you are telling me that throughout residency you've never been sleepy and made a mistake, like it causes problems, right? And it's not just one way, it's bi-directional, right? So the way I like to think about it is that like you are burnt out because you're not enough sleep, and then you make a medical error, and that medical error is going to get to you. And and then the more you think about that medical error, the more burnt out you get, and the cycle just repeats itself, right? So, like, I'm sure by now everyone's experienced it, and if you haven't, it's unfortunate, but most physicians do. It's just the way we practice, which is why we understand we put a lot of effort towards avoiding this. And obviously, it's been extensively studied. Like 10% of patients who report committing a major medical error in the past 3 months had significantly more burnout, like around 80% versus 50%, more fatigue, more suicidal ideations, like 13 versus 6%, than physicians that didn't experience that burnout in the last 3 months. And then it's obviously, compared to people in non-physician careers, burnout is significantly more prevalent, 36 versus 25%. Lower work-life balance, 40% versus 60%. And then, obviously physicians work longer hours, more nights, more weekends. And that, yes, independent risk factor for intensivist burnout is presence of conflict or suboptimal relationship with colleagues and other health professionals like nurses. Although I don't think anyone has it worse than ER docs. Pretty straightforward medicine question. I will throw this in. I'll go a little more into depth. So the answer is like respiratory acidosis with anion gap acidosis. Pretty straightforward to figure out. Simple way I remember this, and like the way I teach like med students and residents, is the way I think about. Hopefully after this you'll never forget it. The way I think about acid-base disorders is it's like a boy band. Everything goes in one direction. So if your CO2 goes up, what has to go up? Your bicarb has to go up. If your CO2 goes down, what has to go down? Your bicarb has to go down, right? So I know a lot of people joke around and say that this is all just textbook questions and never applies in real life. It absolutely applies in real life. A lot of our clinical decision making is done by looking at acid-base disorders. And if there's any interest in like cardiology, EM, critical care, know your acid base, like perfected, especially the compensation and the differentials. Like if I have two disorders, what are the reasons that it's happening? Because then you have to address both these disorders. Versus if it's a primary and a reactionary disorder, like compensation, then you don't have to address the compensation, you just have to address the primary. So, right, when you think about like compensation, you guys know the equation, right? Like if it's high, then look at the PCO2. If it's high, then you know that it's alkalosis, where if it's low, then acidosis, whatever. Metabolic acidosis, use the Winter's formula, 2/3 of the bicarb for metabolic alkalosis. And then I like to put things in a 2x2 box. And in that 2x2 box, at the top is like your respiratory issues, your metabolic issues, sorry, your acute and chronic, and then is it respiratory acidosis or alkalosis. So I just write a square, and then it goes like 1, 2, 3, and 4.5. And then everything plus or minus 2. So for every 10 change in your CO2, you get like a 1 change in your bicarb, or a 2 change in your bicarb, or a 3 change in your bicarb, or a 4.5 change in your bicarb, and then plus or minus 2. And that helps me determine, is it an acute process or a chronic process? And then obviously with winters, you don't stop there. So if you have like a metabolic acidosis, is there a gap or no gap? And sometimes there'll be both, and that's when you do your delta delta. So I know people will do like the equation. The way I keep it simple is that like for you look at this box, right? And so for every, like, no matter what, your body likes to keep electric neutrality. So your sodium and potassium should always equal to your cations, right? So your anion gap plus your bicarb plus your chloride should always equal. So if I get an anion gap acidosis, what's going to happen? The anion gap goes up, the bicarb goes down. And so if I get rid of that anion gap acidosis, right, that extra anion gap that I have, so like your normal's 12 and it's like 20, and I take that 20 and I get rid of that anion gap, my bicarb should now be 12, right? But if your bicarb is like 28, right? So I added it back, which means 20 is way higher than what it should be if I just added that 8 back to the 12, which is 20. That means there's a concomitant metabolic alkalosis, right? So it's much easier for me to remember if I just remember that things just like to be equal. And if I address the problem and I give that number back to the bicarb, whereas my bicarb is at less or higher than it should be, then I have a concomitant acidosis or an alkalosis. Yeah. Yeah. Correct. Yeah. And then mud piles, like take that and throw it out the window, unless you're going to be a family doc or an ER doc, because four of those letters apply to peds, and that's never going to apply to us. And then on top of that, I would still throw it out because some of those we don't even see anymore, right? Like some of the substances that are in that mnemonic. So the way I remember it is like the rules of three for anion gap acidosis. You can have endogenous stuff, exogenous stuff. Endogenous stuff would be your lactate, ketones, and sulfates. So lactate, you can have like your three types of lactate, A, B, and D. And then ketones is diabetic acidosis, starvation ketosis, and alcohol ketoacidosis. And then your sulfates is like if you're like rhabdo, and also if the same things that will cause elevated sulfates will also cause elevated phosphates. So like kidney failure, acute kidney injury, or rhabdo, because look at massive amount of phosphorus secretion. And then obviously exogenous stuff like your alcohols. And then keep in mind like salicylates, patients with like chronic Tylenol use won't be able to metabolize it. And then valproic acid, toluene, you don't see much anymore. And this is the way I remember my non-ion gap acidosis, renal, GI, and then you're basically giving an excessive amount of chloride, right? So when you look at non-ion gap acidosis, it's equivalent to hyperkalemic acidosis, right? You're just basically, your bicarb decreases, and the reason your bicarb decreases is that your chloride amount went up, and it's because you're giving a crap ton. Sense? All right, this one is a fun question. So this, I think, is something that all the fellows should know pretty well, and if not, then we'll kind of go through it, right? So you have a patient with ARDS, so you are practicing lung productive ventilation, and you have 3 patients, all who had changes in their PEEP. And obviously, a question like this will try and throw you off. So really, what the question is asking, and really have to pay attention to what the question is asking, in which of the following cases the higher PEEP justified? So in case 1, it shows, initially you have a higher PEEP and then they lower the PEEP. In case 2 and 3, they have a lower PEEP, a higher PEEP, and then they lower the PEEP. Sorry, in case 1 and 2, higher to lower, and then in case 3, lower to higher. Yeah, but all the questions, it doesn't matter, right? Because the question is asking in which of these modes is the higher PEEP better, right? And so what's interesting is that what you'll realize is that all 3 methods are using 3 different ways to assess the best way to assess PEEP. So when you talk about like lung productive ventilation, what you're really trying to make sure is that the basic premise, if you don't kind of understand this stuff, is that your ideal alveolar recruitment. Think of your lungs like balloons, and you want to adequately inflate your balloon. Sometimes if you apply too much PEEP, you'll overinflate your balloon, and that'll cause barotrauma, right? Because you're providing excess positive pressure, and you'll cause positive pressure trauma. If you underinflate your balloon, it's underdistended, you'll cause atelectasis, and it becomes harder to open up that balloon, right? So one way to think about it is like you look at case 3 is your stress index. So a stress index is that normally you should look like this on your pressure volume curve. So I'm really looking at, let me see if I can draw, oops, I can. So look at the case 3, you see that curve, how it's up, the yellow lines, that's your pressure volume, your pressure time loop. You see how it's slanted like this, right? It's straight, right? So this is ideal. What happens if it's concave like this? So you're over distended. Yep.
And then if it like curves like this, it's like under
Distended. Now, in order to assess this, what you notice about the flow curve, the green one, is that it's in a square line. It's a square box, right? It's not like the one you see in the first one, right? It's not a variable curved flow loop. You're injecting the volume like this, which is uncomfortable, which is why we don't do it. How you see it upstairs, you won't see the flow loops like this. What you see the flow loops is, right, which is how we breathe, right? So it's more comfortable. You get it. So you have to have this straight line flow curve, this constant flow, in order to assess this curve of the stress index. And the machine can actually calculate it for you through calculations. And so if you maintain the stress index around the same, you're good, right? And so once again, over distended, under distended, stress index greater than 1, less than 1. And what you see is that when you change the PEEP, you don't see much of a change in the stress index, which means that it's acceptable, right? Ideally, you want it to be flat. Correct. So what's wrong in patient 2, Gibson? Well, you can't use it, right? You're not assessing your stress index. It's not even letting you. But what is it doing? What's that line that's happening? That curvy line. So you see at the end of the loop, it's like the pressure. You see that yellow line? Yeah. What are we doing there? Yeah. So it's an inspiratory hold, right? So you say, let me blow out, and then you cap it, and then you see what the pressure is, and that gives you your plateau pressure. And what's your plateau pressure minus your driving pressure? I mean, your plateau pressure minus your PEEP, your driving pressure. So studies show that in ARDS patients, your ideal recruitment happens in a driving pressure less than 14. You want to optimize the patient to bring that driving pressure low. And what you'll see is that if a patient's underdistended, your driving pressure will start to go up. You start adding more PEEP, the driving pressure will go down. If the patient's, if you keep adding PEEP, the driving pressure will start to go back up. So it's almost like a U curve. So if it's over distended, the driving pressure is high, so you decrease the PEEP, and then you keep decreasing the PEEP, and then the driving pressure goes back up. So now you've decreased the PEEP too much because you've underdistended the balloons. Does that make sense? To keep it just the right amount of open, right? Yeah. And you know that because you literally pause it and you see that when you're not giving air, what is the pressure in the balloon like? Because this will be too much pressure, this will be too much pressure, right? And so your driving pressure in that case is very useful. Now, case 1 is a little tricky. So what's different about case 1 compared to case 2 and 3? Is that instead of being in volume control, you're on pressure control. So you can't apply those same dynamics. And so the trick, you're in pressure control, right? You're like, here, you apply a certain pressure, and then you get your volume. So your volume that you're getting is your dependent variable. So you have this patient on a PEEP of 14, and then you decrease the PEEP to 10 while receiving pressure control. And what happened is when you went from 14 to 10, your exhale tidal volume went from 435 to 530. So if the tidal volume is a dependent variable, a decrease in PEEP should result in increased tidal volume if you had over distension with the higher PEEP. Does that make sense? Correct. Versus like the other way around, if you decrease the PEEP, that should have a lower tidal volume, right? Because you've now de-recruited. And that would support a higher PEEP. But here it was the opposite way. So the patient was already like over distended, right? And so that's why that one is not, the higher PEEP is not recommended. Make sense? So I would really get comfortable with all of this because that's how you titrate. That's how we titrate our PEEP at bedside. Obviously, you guys aren't allowed to touch the ventilator. But come find us when you want to assess and say, hey, look, I want to see why we can't adjust the PEEP. And then we can kind of go through with you. And then hopefully all the fellows are doing this like on an everyday basis with every patient that's ARDS. Well, if you build the trust with the therapist, then you're good. Just let them know what changes you make. All right, question 10, last one. So you look at the CT scan, ouch, right? And then I don't have to look at the rest of the question. I just look and see which of the interventions most likely restore him to some level of independence. Right, so the patient has what we call a malignant middle cerebral artery syndrome. And so the patient has a high risk of cerebral herniation and death. The only intervention that has been shown to improve outcomes in this patient is a hemicraniectomy. You're literally opening up the part of the skull and taking that part of the brain out because it's malignant. It's just going to keep cycling on itself, and that brain is going to keep herniating. So a couple big trials for the fellows to know: Destiny, Hamlet, and Decimal, done in patients from 60 to 80. Less than 60 years old, and then the Decimal 2 was done in patients 60 to 80. And all of them showed an improvement in patients with a hemicraniectomy just keep in mind that none of these patients achieved a functional independence. And this is for strokes. It does not apply for traumatic brain injury. And hemicraniectomies are not recommended for traumatic brain injuries. Seizure prevention, yes, you can mitigate seizures, and that can further, if you have a seizure, your intracranial pressure is going to go up too. But it's just unlikely in the situation. And then INR of 1.3, you don't have to do anything about. Mannitol is important to know. It's a great drug to use along with hypertonic saline, but they have not been evaluated for outcome benefit. It's been shown to decrease intracranial pressure in a number of diseases, but it's all very quick, rapid on, rapid off. And if you keep using it, it stops working, right? Because you've gotten rid of your pressure gradients. Same with hypertonic saline. Yeah, that's really it. And then there's obviously it can get more advanced, bunch of considerations of whether you're going to perform the hemicraniectomy or not. But obviously, we're not managing that patient here. We're going to a neuro ICU with capable neurosurgeons. Thanks, guys. Have a good week.
Thanks, appreciate it.